Hello students, we will discuss a operative topic with the post-operative status. Look at this. What is this? This is the open appendicectomy. See that? You can see the appendix, you can see the mesoappendix with the appendicular artery, which is a branch of ileocholic artery, and sometimes accessory appendicular artery of Echachalam is another thing which you have to remember. And this is the acute appendicitis. Typical, you can see the cecum here, you can see the tinea here. This is the base. This is the tip of the appendix. This is the Babcock's forceps, which is one of the uses of the bobcat holding the appendix. Bowel should be held with the Babcock's forceps, not Alice forceps. This is the Babcock's forceps which is holding there. This is the appendicectomy. See that spino-umbilical line. This is the McBurn incision, MacArthur incision. Lateral 1/3 and medial 2/3. 1/3. 2/3. Lateral 1/3 and medial 2/3. So this is operative open appendicectomy. Indications are acute appendicitis. Ideally, laparoscopic appendicectomy is the ideal thing. In situation is not good. First appendix, critical patient. Patient can't effort. Mainly there is the indication in a peripheral center. You can do this one under spinal or general anesthesia quickly. So McBurn incision, skin after cleaning and draping, skin is incised, 2 layers of superficial weight incised, external oblique muscle is incised along the line of incision, and gridiron incision it is called as gridiron incision. And internal oblique and transverse abdominal muscle is split. It's a muscle splitting incision. Split across along the line of fibers. Peritoneum, shiny peritoneum, pearly white is identified. It is held with the artery forceps. Bowel should not be held carefully. You have to feel it. 2 artery forceps are placed. Then you have to cut with the knife obliquely. Then open and see. Confirm that you are not injured bowel. Then hold the edge of the peritoneum with the artery forceps. Then cut the peritoneum along the line of incision adequately. Then put the retractor in the deeper plane, both retractors, deeper or deep retractors. Then identify the cecum by tinea. Hold the tinea with the Babcock force, gently trace it down. Then you can feel, put your finger and feel the appendix with the tubular structure, and hold the appendix with the another Babcock forceps. Lift it and deliver it outside. You can see the mesoappendix with the appendicular vessel. Gently dissect it, and any adhesions are there, release it from the appendix to the harmonic structure, and clamp it and ligate with the vicryl or silk. Appendicular artery properly, securely should be ligated, otherwise bleeding occurs, torrential hemorrhage, eventually reactionary hemorrhage can occur. Then lift it properly and reach the base of the appendix with the proper dissection. Once you reach the base of the appendix or near the cecum, then crush it with the artery forceps, which makes the mucosa to oppose each other. Again apply same artery distally, then transfix the touched area with the 2-0 polyglatin 910 vicryl suture, figure of 8 suture. Then after that one more suture with the silk or vicryl, proximally free ligature has to be. So 2 ligatures should be there proximally, and distal to that appendix is cut with the 15 number blade, and stump is cleaned with the antiseptic solution. Olden days we used to put a purse string suture like this to the vicryl along with the around within a centimeter surrounding the base of the appendix. Then when to tighten that, and assistant will push the stump and it will get buried inside. And otherwise neuromuscular Lambert suture can be placed so that bury it. Now currently it is confirmed and used that burial is not necessary, so most of us won't bury it. Same holds good for the laparoscopic appendicectomy, where 2 envelopes are placed and burial is not done. If somebody wants to burial, you can do purse string suture or 2 Lambert's neuromuscular suture, they place it, get buried. Now after that, close the wound, give a warm saline wash if required. Suck if there is any infected fluid there, suck it properly in the paracolic area around the cecum, and in the pelvis, very important. Pelvis sucking fluid is important, other pelvic abscess can occur. And after that, close the peritoneum with the vicryl, then muscle layer with the vicryl intro suture. External oblique you can put continuous or interrupted suture. Subcutaneous and skin sutures you can place. Sutures can be removed after 7 to 10 days. Then antibiotics should be covered for 7 to 10 days. And painkiller, you can start oral next day. And drain can be put, tube drain, if there is a pus and infection while opening. And this, if it is so, pus should be sent for culture sensitivity. Ligation of the base of the appendix properly is most important to prevent fecal fistula, leak, and further problem, further local infection as such. And control of the ligation of the appendicular artery also very, very crucial, prevent the reaction and hemorrhage. So done in acute incision, I already told, I have discussed everything. Difficulty in approaching the appendix with this gridiron incision, muscle splitting incision. Then you can extend the incision by cutting the muscles laterally, above and laterally, that becomes Rutherford Morrison incision. And when you do that, you may injure the ilioinguinal nerve, causing the weakening of the posterior wall of the inguinal canal, eventually may cause right-sided direct inguinal hernia. Medial, if you cut, it is called as Hollow-Davis incision, and crease incision, instead of McBurn incision, same muscle pitting incision, the crease incision is called as a cosmetically Lance incision. In a difficult case, the right pyramidal incision can be used. So this is the scar here, you can see. Scar you can see here. And procedure I already told. Cecum tinea ileocoel junction, mesoappendix, and often before closure you can pull the ileum for a few feet proximally, see that there is no Meches diverticulum to confirm that. And complications are paralytic IS, reaction hemorrhage, residual abscess, adhesions, intentional obstruction. These are the complications. Portal pyem in a severe patient. It's not that common. Multiplying organism abscess in the liver is called portal pyemia. Very distressing complication, life-threatening complication with the jaundice, sepsis, hypotension, toxicity, uremia, all those things can occur. Severe jaundice. That is not common, of course, can occur in severe bacterial infection, virulent organism, and when there is a immunosuppression, HIV patient, steroid, old people, all those patients. Right indirect inguinal hernia if you cut the iliainguinal nerve during appendicectomy incision. So the different complications which you have to remember. So answer the MCQ. The patient has undergone appendicectomy surgery for burst appendix. On day 4, yellowish colored foul-smelling discharge is seen through the wound. What is the most worrying complication? Wound infection, fecal fistula, abscess, wound dehiscence. Give the correct answer in the comment box. I will give the answer later. So students, go through my SRB's clinical methods in surgery, which has got a video lectures of each topic. So many topics are covered. Every topic as far as CBM syllabus is covered. How to examine the patient. Swelling, ulcer, arterial disease, venous disease, thyroid, breast lump, mass abdomen, briefly orthopedic, every system, whatever your required thing, everything is covered. There is a video of how to examine of each topic, and principles of examination is good, and differential diagnosis in the table format is given, and briefly investigation. Suppose treatment is not a topic will be covered in a clinical method examination, remember. And many photos of the most of the conditions with the illustration. Photos will tell the clear idea about for the students how exactly condition looks like. So covers everything with the beautiful photos, and it also gives the instruments, specimens, then operative surgery briefly. Everything is covered. Small images also it is covered. So it is more than sufficient for all undergraduate, postgraduates of any system to learn. Very basic required thing for the surgical field is clinical methods. So please go through that and purchase that and make use of it. My SRB manual of surgery is very popular. It covers a theoretical aspect, everything, principles, treatment in detail, briefly technical aspect, and with the photos, illustrations, quotations, all topics with the specialty, urology, cardiothoracic, neurosurgery, and operative surgery instruments. Again, it is covered in this book also. Every quotations, and you should worldwide also, actually including our country, everywhere. And please, you can make use of it. My operative surgery book, SRB's operative surgery atlas, that is a 2-volume book, covers in detail operative technique of surgery, all surgery, small surgery, major surgery, everything with around more than 10,000 illustrations and photos. It gives very good principles and technical, step-by-step technical aspect. Very useful for postgraduates. Not much useful for undergraduate, but it's a postgraduate book and consultant book and learner after MS. It gives everything. You can, before going to surgery, you can always read this book. I will memorize your steps and do the surgery properly. Every topic, general surgery, gastroenterology is covered in detail, step-by-step with illustrations. And my SRB's atlas of tissue approximation, small book atlas, 100 pages. How to do the suturing, tissue approximation, including laparoscope suturing with the video. It is covered. So any basic learners, suturing is very important surgical field as a skill actually. Dissection and suturing, so the two parts of the surgical skill. So that is also covered very well with videos. You can always go through that. And my website, please subscribe, all of you. Your daily lectures are there, live sessions are there. My Digihour lectures through JP Publishers, around 220 hour lectures. Entire thing as for CBM is covered with the examination part, with all topics of CBME, ulcer to operative surgery, instruments, specimens, examination, specialties, basic, everything is covered. You can always purchase for 1 year and have a clear idea about the surgical topics, understand very well and helpful for your exam, NEET, MCQs. Also, it is there both in manual and my lectures. So students, I hope you have understood this lecture very well. Thank you very much.